All right, everybody. Welcome to another edition of the Leadership in Live podcast with your host, Ricardo Rice, and my co-host,
Simone Cherie.
All right, so we're back, and it's crazy to be back in the studio every week. Like, it feels like it's been decades since it's been every week. And yes, you guys, you're going to hear me say that probably for at least the next 3 weeks, because it's crazy. It's just really crazy. All right, so today, y'all know how I love family, and one of my cousins, my big prominent cousin from the good side, is in the studio with us today.
Lord,
so I'm going to let him introduce, from the good side, I'm going to let him introduce himself, and then we're going to jump into some. Simone thinks this is a very interesting topic. We're going to get into some stuff after he introduces himself. So go ahead and introduce yourself, cuz.
Well, thank you. Good morning, everyone. I'm Wayne Boatwright. I suppose I should say Dr.
I was about
Wayne
to say, so we're just not going to say doctor.
Okay. My role has been for the last over 20 years, it's been an executive in the area of diversity, inclusion, and now equity in healthcare. And so I work for one of the largest hospital system in New Jersey, Hackensack Meridian Health. And so I was in that role for 15 years. And so I actually started the diversity initiatives for the organization until I retired a couple of years ago. So it's very nice to be here.
It's very nice to have you. So we're going to get into this topic because Simone is just so excited about it. So you go ahead and drop the topic.
Let me just say I'm excited mostly because of what you've shared with me and the fact that actually Ricardo and our guest have inside information that I think is just fascinating. So that's why we're talking about this. I know that if you've been on social media at all this week, you've already heard a lot about Alex Murdaugh. You've already heard a lot about the ongoing murder trial and frankly, this very dramatic style trial. Like you can see these attorneys really trying to milk this like for their 15 minutes, like being very engaging and being very, very dramatic at multiple points. And for whatever reason, so the defendant in particular has chosen to take the stand at his own trial, which actually is not very common. I feel like people probably think it is. If you only follow these high profile cases where people are, my assumption is so wealthy that they decide they're just going to take the stand, but it's usually very rare and usually very bad advice to take the stand.
I don't think they wanted him to, honestly. I think he just kind of did
He probably insisted. I got to know the defense strategy behind that, or if there was no strategy, he just insisted. But at any rate, so Alex Murdaugh in particular was teary at times. He was discussing the now, I think, infamous 911 call, which is now completely in question, in which at this point he's admitted to having lied to police. So lots of fascinating developments there, but not as fascinating as the fact that our very own Ricardo is all too familiar, and I think for that reason probably a little unimpressed with this family. So can you just paint like a quick background picture as to like your knowledge and experience of the whole family?
Oh, good God. Okay, so I was raised primarily where they're talking about, Hampton, South Carolina. So you have to picture almost Mayberry-ish, that racism was small town, predominantly white-ish to say the least. I grew up, and I'm gonna say it because the people that in my age we know, like it was kind of bad-ish because there was literally a swimming pool that black kids could not go into. Like I grew up with that. It was unspoken, but it was a thing. Like the bus would drive by and we were like, oh my God, we would love to go. And it's just like, no, you cannot go to that pool. But they would say, oh, yeah, everybody's welcome. You never saw a black kid in that pool. So it was kind of implied racism in this area. We grew up knowing the Murdaughs. The Murdaughs were kind of the mob family in Hampton, for lack of better terminology. They had the biggest law practice in Hampton. If you were in trouble, you either want them on your side or with you and not against you, right? Because that was just what it was. It's the Murdaughs. My father has elite car washing business. So he does business with local businesses. He washes their cars. He has contracts with them. Murdaugh's was one of his contracts. So we wash. I say we because, yes, people, I did manual labor when I was 14 with my father, washing cars in the cold and the heat. Nobody believes me. Yes.
Character building.
Whatever. If you ask him, yes, he's gonna agree to that. And it worked. My father's ideology was, if I make you work hard now, you'll avoid it as you get older. He was absolutely right. I do not even want to wash my own car.
What about the doctor? Was there any moments that you can recall with observing the Murdaugh family?
Well, I think it's interesting you talk about the fact that you'd really like to know what the strategy is,
Yeah.
especially in regards to him kind of defending himself. But I think it's kind of like Ricky said earlier, they just kind of knew everybody. So I'm not sure that it was necessarily an assuming strategy versus I know everybody, I can just get up there and do my thing. And that's how
Gotcha.
I would say kind of incestuous it was because either you went to that Murdoch or you went to other Murdochs. And not sure a lot of times whether they were professional in all areas. I don't know if they did divorce and civil and et cetera, we're training at, but they did divorce and civil and
Gotcha.
those kind of
Gotcha.
things too. So I think it's kind of interesting that a part of it is they've got such a legacy in the area until where others may really see a strategy to say, hey, you don't want to get up there and talk about what you did. I think they're saying everybody knows me, they know my heart, so I should be okay.
Yeah, I mean, and that's what's so fascinating too, is that a lot of times what it comes down to is your credibility or how credible you appear or come off. And I think the reason people probably, well, I think most attorneys dissuade you from testifying in your own defense is because chances are, even if it's just for a second, some part of you may not look all that sympathetic. And it's in particular in this case, we're talking about 2021 murders. The trial just came underway this year, but Alex is also facing over like 100 counts plus of financial crimes for every financial crime you can think of: tax evasion, fraud, embezzlement, larceny, like every single financial crime you can think of. And because all of this has come out, and as all of this has come out, he's also been considered either a circumstantial, unsubstantiated part of other murders, not 1 and 2, but 5 other murders.
Well, here's the thing. We're talking about decades of mob action. Like
seriously.
So
Yeah.
for him,
In Hampton, South Carolina.
you got to think about it. He's growing up watching his uncles, his fathers, even the women in their family just kind of be like superstars in this county. So they're not accustomed to being called on the red carpet about anything. So in his head, he's just like, this is just another thing, and I'm good, and nobody can touch us because we're the Murdochs. Yeah, that's cute when you're in Hampton.
Right.
But now that we're not in Hampton, you're not being tried by people in Hampton. Yeah, now you're on the world stage. Like at our last gathering, which is about 2 or 3 weeks ago, it was funny because it was a topic of conversation, and it wasn't the trial itself. It was like, well, they've been doing this for decades.
Yes.
So the question for us is, how far are they going to dig? Because if they keep digging, they're going to find more and more bodies, because we're talking about decades of just backroom dealings, the good old boy system. So that's our question when we're all together. It's just like, how far are they going to dig? How vigilant are they going to be in this? Because, Alex is just now. We're not talking about decades of this kind of behavior.
Right.
So
For sure.
in his head, it's just like, you can't touch me.
But one of the decedents as well, right? So his son, Paul, there was, Netflix special out right now that talks a lot more about this incident, but one of the most, I think, popular clips that you'll find on YouTube regarding Paul was his ex-girlfriend talking about how much abuse she suffered in a relationship with him, how he was physically abusive to her, verbally abusive to her, how he was constantly intoxicated, and he was in legal trouble for a death involving a boating incident where he was also reportedly incredibly drunk.
Yes.
So it's almost just like this whole cluster of, I don't know if it's like karmic events all taking place at
absolutely.
once,
This is
where
absolute karma.
it's just become far too much. But it's also like the timing is insane. It's insane. And now 2 years later, this individual is dead.
Well, it's funny because when they do a lot of the aerial shots, like the place that a lot of this took place is literally 20 minutes from where my grandma lives or used to live. So it's just like,
It's
know
wild.
these
Wild.
areas, which is funny because, we knew it was there, but nobody paid attention to it. So now that they're bringing light to it, it's like, wow, that was literally down the street from grandma. Like, and I live with my grandma. So it's like, this is really interesting. And a lot of the aerial shots, the places they showed, it was like, oh my God, that's Rigdon's. Right. Oh my God, there's my father's shop. Like, it's really crazy to be on the world stage for stuff that we've known since I was a kid and probably since Cosby was a kid. Like, it's
absolutely
crazy to see this moment now.
Yeah. I don't imagine a great outcome here. I think when you are missing a very clear part of your story, being where you were the night in question. I don't see it going very well. Going very well for you. I think that's a pretty big one to have flubbed or to have lied about. Yes. So I think this is probably.
I mean, this is gonna sound weird to say. I almost feel sorry for Alex because you're paying for crimes of your legacy. Like, you're literally paying for crimes of your legacy. I mean, that's not to say he's innocent. I don't really care either way, honestly. But it's the principle.
But do you believe that he's innocent?
His wife and his son? I believe that it's funny to watch them kind of decide what they can and can't say or what they should and should not say because they're so used to covering up stuff. So that, for me, that's the interesting part. It's like, when you keep talking and you're in the moment and you're not used to being in a moment this big, are you going to remember what not to say and what not to get into? That's the biggest part for me. Like, I'm just like, he's going to slip up and say something that he probably shouldn't say. Right. That's going to start a whole nother investigation. If I was interested in anything, that's what I'm more interested in.
Wow. Well, I guess we'll have a little bit more to find out on Monday when we resume. Because at 4:49 Eastern time, they were done and they wrapped it up for the week. So I'm very much looking forward to seeing what the outcome of this is. But also, it's just, what a shame, though, for the family of Mallory and for those who are still kind of looking for their justice and may never get it.
Honestly, they're not used to getting justice with the Murdochs. If we're very honest, they're not used to getting justice. Like I said, these are not people you want to be on the other side with. They're just not. Like, I keep saying mob action, but it's literally like that. Like, it's the Murdochs. Yes. You don't want to be on the other side of the Murdochs. So most of the time, especially us, you just kind of know it's like, oh, it's the Murdochs. Just keep moving. Don't even, just leave it be. Keep moving.
On the other hand, if you are a criminal defense attorney and you are looking for a place to set up shop, or you're kind of wondering where you could build your practice, maybe Hampton is a great place to be in, actually, for that exact. Maybe there's an opening now in the market.
They haven't been taken down yet, so let's you still want to stay off that territory.
I hope so. Maybe we can do a quick transition topic because it is semi-healthcare, healthcare related, but also some political news. So we've talked for the last several years, I think, about the change and, not just the overturn of Roe v. Wade, but we've also talked about some of the changes with regard to state legislation, access to pregnancy termination, and we talked a lot about that in Georgia in particular. So there is even in Georgia's legislature, which has only been in session for about 7 weeks or so, with all these other topics on the horizon, there are still continuing conversations about ways to restrict or restrain access to abortion. One in particular, which aims to charge people who seek abortions with homicide, even though this was, I think, one of the big talking points by folks who were, wanting to overturn, the Constitution, Roe v. Wade, but also saying we don't want anyone punished or anyone penalized. That was a big talking point from people on the right or people who were pro-life, which is that, well, we're not getting anyone in trouble. We want to dissuade the practice. And that may no longer be the case. There would be it has been a bill that would consider an unborn child at every stage of life a human being and would consider any attempts to end a pregnancy to be homicide. Now, this is not supported by the larger public, even by the larger voting Republican public. 64% of people do not believe that there should be any criminal penalties for people who do seek abortions or obtain abortions, regardless of the law. But yet this bill is still introduced. So we will follow, like we do with so many other state bills, this piece of legislation, but would love to get immediate thoughts about this. There's also similar legislation pending in South Carolina, by the way.
Ugh. I'm from South Carolina, but I swear the things they do in South Carolina, I just sometimes just shake my head. Yeah. We just got to stop having these one-sided conversations about these things. If you're going to make everybody have a child, when the child gets here, what are we doing? Right. Like, if I cannot afford a child, an abortion is the only thing I can think to do because I already have 6 kids, and now you're telling me I have to have a 7th child, I can't even take care of the 6 that I have. So, and you guys are always tampering with, the programs that are there to help people who can't afford to have kids. You're always tampering with that. So it's like, you want us to have kids, but then you don't really want to aid if I have the child, because the best decision I could come up with was, I don't need to have another child. Right. Now, granted, you can say, well, you should have used protection and things of that magnitude, and that's cute, but we're talking about reality. And in reality, if you're going to make me have a child that I can't afford to have, what programs are in place to ensure that this child has a good, healthy life? And primarily, we are talking about African Americans. So it's like, what are we really doing? We got to stop having these one-sided conversations. But if it's not you, you don't really care. You just want what you want. Right. But what do you think, Dr. Boatwright?
Well, I think it's interesting, as Simone talked about some of the specific data and et cetera. When the topic we're going to talk about a little bit later, there's still racism raises its ugly head in the area of healthcare. And so it goes back to exactly what it is that you just said. And that is that even though there's a ton of individuals out there protesting against this, there still needs to be the focus around what it does to African American women. Because, and I remind people of this all the time, and I got into this discussion with someone who was really taken aback by the decisions that the courts made. And I was in agreement with them in regards to that. But the fact of the matter is sometimes it's deeper for the women of color that are impacted by this. Mm-hmm. And, you know, I think we need to not forget that many years ago, the suffragettes, which were white women and black women trying to get together to vote, and white America said to them, if you depart from the black women, we'll give you the opportunity to vote. And so they received their voting rights. And so I think it's going to be important for us to make sure we keep our eye on the fact of what does it do to our women of color versus just kind of like overall mentality that, you know, is going to benefit everybody. Because as we know, those benefits do not benefit our women of color. And so, again, I think that it's interesting in the sense that some of the legislature and now this last information about it could be considered manslaughter and et cetera. But I still think we've got to look very clearly and see where the racism still shows itself even in this type of a decision.
Yeah, no, I think that's an incredibly good point. But also, I think there's a question here, not just about the healthcare implications, but you have to think about how inflated our criminal legal system is and how full it is.
Exactly.
Right? Like, we already have mass incarceration, we have overcrowding in so many of our prisons and so many of our jails. And what are we talking about doing here? That's like, what's the positive outcome of a situation like this? It's just additional people filling up institutions, people who are probably law-abiding and paying taxes and working jobs. And then what are we doing? Like, how is that an actual deterrent?
Yeah, and you take a person like myself at my age, we really subscribe a lot to these conspiracy theories. And so one of the things that we look at is the amount of men of color who are incarcerated, taken out of a scenario to be able to make an impact, such as voting and et cetera. And it seems to be an effort to really minimize and negatively impact the African American population.
For sure.
Well, is this a way to do that to our women of color? All of a sudden, you've got these individuals who are good paying and doing the things that they should. And because of making important decision in their own life, as Richard talked about, now all of a sudden they're standing in front of a judge defending their ability to be able to. So,
yeah,
I think their body. That's the part that gets me. It's your body. Like, listen, I just, the thought of it is ridiculous. Like,
I agree.
To tell somebody that you have to have a child. Like, and then again, a child you probably can't even afford, or it just may not be a good time in your career to have a child.
Right.
Like, to tell somebody they have to do that is just, who are you to tell somebody that? Right. But again, you know, Republicans play the long game. So like Dr. Boatwright was saying, they play the long game. So in the long game, it's okay, black women on the rise, you know, things of this magnitude, we got to get them now. Because we pretty much got the black men, we want them, we need to get them now. Like, they play the long game. So these are the times that I get annoyed with Democrats. These are those times. It's just like, do y'all ever play the long game? Or are we just looking at our hands right in front of our face? Do y'all ever play the long game?
Right.
Y'all know, we know what we're up against.
Yeah.
We know what they do. It's just, it's annoying.
To me, it's also just such an illogical, such an illogical train of thinking in terms of even regulating it, right? Because regulating pregnancy, it's almost like, I feel like to do something like this in a way that made sense, you would have to violate people's civil rights in the first place. You'd have to stop people from engaging in sex in the first place. There's just no other way that you could determine whether or not someone is pregnant in the first place, right? So like it's completely retroactive legislation. You know, it's almost like allowing everything to be, you know, close or nearby and legal, and then once somebody uses it, it's illegal. Because you can't stop people from having sex, and you definitely can't stop people from getting pregnant.
Abstinence. That's what this revolves around. They
right, but it's like, how do you legislate abstinence without violating civil rights? You just can't do it. So you have to go all the way with just completely controlling human behavior. There's just no other way around it.
I wish I could go into the multiverse. I would love to see what a Republican world looks like. I just sometimes I wonder, what does a Republican world look like?
Handmaid's Tale.
I mean, like, seriously, like, what does the world look like to Republicans? Because I'm just like, the stuff you guys come up with, it's like, who are you really
and
catering
fixate
to?
on all these years later. But okay, I think that's probably enough. I'm definitely going to continue to watch it, and like you said, there's just such clear racial implications for this, and I think just class implications, to be totally honest with you. Although I do think it's fair that many people who do seek abortions, I can't remember the percentage, certainly the Georgia percentage, but I know as of 2020, about 40% of people who did seek abortions in the annual year of 2020 were already mothers, did already have children. We're grown adults, grown women, not 15 or 16-year-olds who just need more sex education. So these were grown adults making adult decisions. So yeah, I think there's a whole lot more to follow, but you can't deny the racial implications for sure.
I mean, it's just asinine when you just think about these things. Again, I just wish I could go into multiverse. I would love to see what the Republican world looks like. Just love to see it, because I'm sure there's no unicorns or rainbows.
No.
But I would love to see it.
No.
All right, so we're going to shift and get into diversity and inclusion in healthcare with Dr. Wayne Boatwright.
That's very nice.
All right, so let's start here. What did healthcare look like when you got into it? What did it look like?
I think there was an effort at that point to try and be progressive and begin to put some things in place that would address the issue of diversity and inclusion. But I think one of the reasons that healthcare has been so extremely slow is because of the fact that those individuals that are decision makers and leaders refuse to have the discussion about the impact of racism in the area of diversity. And so in as much as it has been scooted for many years, it's been interesting, as I said earlier, that this new COVID strain has literally once again brought up the issues and the implications of racism in the area of healthcare. And so, I don't want to, give it a long history, but just some indications as to some of the impact that it has had. So for an example, if you're Black or Latino in the United States, you're almost twice as likely to die from COVID-19. We're talking about a pandemic that just started. Native Americans are more likely to be hospitalized with the conditions more than any of the other groups are.
Really?
Yes. And so what begins to happen is this same pattern of these results that are negative begins to draw the same level of long-standing health inequalities that people of color have faced for many years. From cancer, prenatal care, there are more African American women who have C-sections than vaginal deliveries than any other women in the country. HIVs, even amputations. And so in our healthcare area where you have people who have issues with high blood pressure, et cetera, more people of color are likely to have a foot, a leg, or arm amputated versus other people who get vein strengthening exercises and et cetera. And so again, it raises its ugly head. So again, it's indigenous people of color are still being impacted by these horrible results. Now, here's the thing that I think is really interesting and how far back this has gone. Because there's a lot of training and education now in the area of healthcare called unconscious bias, which basically, an implicit bias, which basically talks about the fact that you may have a bias that you're unaware of. Well, if you're a healthcare professional, and specifically a physician, and you have those type of perceptions and behaviors, just think about the outcome on people of color. There's only 4% African American physicians in the United States when our total makeup is 13%. And so you have these physicians literally going to surgeries and et cetera with these kind of behaviors. And so, as I got prepared to spend a little time today, I wanted to talk about, so where does all of this thing started with? Well, there's a study called phrenology, which basically people think they can determine characteristics by the size of your skull.
Wait.
Okay, so this is
yes. This is where this thing started. And so, if you've ever watched Django, and the slave master brings in the skull, and said there's a portion of the skull in the African American that causes them to be more easygoing and more better.
Yeah.
So people for many years have literally supported their ability to have slaves by watching the
Yes,
the
the
shape of
scientific
people's head.
justification. Can you also explain this for people who don't know? Because I know there's another term for it. I don't know if it's something genetics. It's
Genetic predisposition?
it's with regard to racism. I don't know if it's I can't remember a more colloquial term, but can you talk more about what the implications are? Because you talked about some procedures like amputations and C-sections, but like for people who don't understand like what that means, like what that leads to, can you just really underline like the quality of life differences and like the impacts?
Yeah, absolutely.
For this different treatment?
First of all, let's talk simply about something that a lot of African Americans deal with, and that is the area of high blood pressure and diabetes and those kinds of things too. And it just falls along so many different lines because, number one, it kind of goes back to one of the things that Richard said earlier as we were talking about, and that is that, or you may have said it, you want people to abide by these things to be healthier, but yet they're not available. So for an example, when I lived in the area of New Jersey, and specifically Camden, New Jersey, and the people that were very, very unhealthy and difficult to have a quality life and et cetera, well, it's considered a food desert. There is no supermarket for a mom to go and get fresh food for the child. And if you do, you got to go 4 miles on a bus to get grapes that cost 3.5% more than anything else. So all of a sudden now it seems a lot less expensive for you to eat Cheetos and a Coke.
For sure.
Versus trying to get fresh food. So on the one hand, you're saying that people are unwilling or can't affect their health and their impact, but it's not there for people to be able to do that, which absolutely affects people's quality of life. And so when you begin to talk about these racially impacted things in the area of healthcare, and I was talking about kind of determining the shape of the head. There's a device called a spirometer, and it is used to determine the lung capacity of individuals.
Okay.
Well, back in the Civil War, they inappropriately saw that whites' lungs had a larger capacity, so therefore they felt that the African American was not as strong a body, not able to be able to do the work and do the job and et cetera. So even today, in this century today, the spirometer has to be race corrected just to make sure that these things are, and it's really, I mean, it really is throughout. So, and I'll give a little bit more relevant example because my uncles and I, when we get together, we talk about this all the time, which is the prostate problems that we have. And, you know, we all know what our levels should be and et cetera. And if you are within 0 to 4% as an African American, or as a man, you should be in pretty much okay. Well, if you come from a history of prostate issues, if you come from a history of having problems, that 4 is not a good number. We need to be between 1 and 2. And so what happens is if you don't have a physician that is sensitive and aware of those kinds of issues, then you could in fact have a problem just because the structure is so racist.
So let me ask this question because we're talking about what we're talking about is a thought. So I've heard that there is a belief that African Americans have a higher threshold of pain, which is why doctors tend not to, and particularly with women, tend not to be sympathetic to it. It's just like, okay, well, you know, a woman says that she feels such and such, and it just goes along with such and such. Is that a thing that they actually believe that we have a higher threshold of pain?
It is, and if you will look at some of the statistics in regards to people going in to get pain medications for some of the same issues that everyone else are dealing with, people of color and African American are less likely to get that appropriate pain medication that will address that pain, but also be perceived more as trying to be drug seeking. And so therefore, there's the issue of not really wanting to provide that. And so, yes, that in fact really does occur. I think one of the other things, and again, I don't want to get overly carried away, but I thought that the one issue with COVID-19 that I thought was really interesting, and when I was in the role, I spent a ton of time with the healthcare community, basically, and the African American community, talking about COVID, talking about some of the trials that were going on, and et cetera. And many of the companies did not understand why the African American community was so resistant. And so one of the things that I really appreciated about Dr. Fauci, who I was with him when he was at the historically black universities, you have to make mention of the Tuskegee study.
I was about to say it all.
You have to make mention. And the thing that people forget is this was a study that was scheduled for 6 months that went on for 40 years.
Oh, my God.
Yes. This was in 1932 when there was the advertisement that basically said free blood tests, free treatment. And there was 399 men in that group that had syphilis that was never treated. They were just observed until they died. Neither them nor their families were told about this until 1972. Oh, now, you think 1972, we know some of those people. So you have individuals who are walking around literally being aware of a study that did what it did to people, and now you're asking them to participate in another study. And so again, we have put a lot of things in places to make sure that this doesn't happen again, but you at least have to make mention and bring some attention to the fact that this in fact did happen. And this is why people are uncomfortable in going through studies and these kinds of things too.
Yeah, but isn't that the scary part? Because I was talking to a friend of mine, she's a doctor, we were talking about ovarian cancer, and she got into case studies and how it's a very big issue because African Americans are not prone to be part of case studies, which makes it harder to create medications that are specific to their group of people because they're not being studied.
Yes, and I think to some degree that is true because, but you do have to look at how you're setting up these studies. And I've said this to people all the time when they're putting them in place. I've got to see someone who looks like me. I've got to see someone who actually understands it. And when you begin to talk about what some of these side effects and et cetera may be, I need to have someone who can basically understand what that does to me, what it means, and all of those kinds of things too.
The intentionality.
The
matters.
intentionality of it. I mean, let's even be more recent than the Tuskegee, Henrietta Lacks. Henrietta Lacks was an African-American woman in Maryland who had a very aggressive cervical cancer. Unfortunately, she died from the cancer, but her cells remained active. These are called the HeLa cells. Now, I grew up understanding about the HeLa cells. This woman had no idea, her family had no idea, that they were using these cells to address cancer throughout this country. These cells have been in space to see basically how people are affected by these cells. I mean,
Wow.
I'm talking millions and millions and millions of dollars have been made off of the use of these cells, testing cancer and that kind of thing too. So the reason this came to the forefront over the last 4 or 5 years ago was that an author wrote a book about her and how the cells, without her consent, was being used, and how her family has never been impacted positively by this, to the point where 90% of the people in her family do not have health care insurance.
Wow.
Now, they have contributed. They have contributed to this cancer research and these cells, and they had no idea about that. And that's the most recent thing. I'm talking the last 4 or 5 years. So these are the reasons a lot of times when we sit and we talk to family members and they make comments like, I'm not putting that stuff in my body, I'm not doing this, I'm not doing that. Yes, some of it may be that it's, old discussions that were happening in the past, but there's still relevant things that people can talk to about where there was really no consideration for how people were brought into these studies, the results of these studies, and what do we do to make sure that these things doesn't happen again. So, there is a lot of issues still associated. And even when you begin to talk about our physicians, we have a small amount of physicians. But when I taught at the medical school for our physicians, of the percentage of individuals who ended up being actually practitioners was minimized at least by 8% because of the hassle they got when they went in to treat people. So you're a young physician, you're in residency, You go in and treat somebody, they think you're the person coming to clean the room. They think you're the assistant. They think you're this. They think you're that. And so when you have a group of young physicians who don't really have someone to talk to about that, they just decide,
mentor or coaching, or
I'd rather do something administratively than to do something clinically, because I'm not going to continue to take this kind of feedback. So
let me ask another question similar to
Please.
Ricardo's, is like that balance that you have to find, because there are some things that I think, and as studies have come out and we've learned that there are base differences sometimes between people based on their ethnic composition.
Yes.
And what they may be not even just necessarily prone to, but like what their experiences may be or what treatments may be acceptable. Like that knowledge sounds really, really helpful, but it also sounds like it could turn into recommendations either not coming to you because you're not seen as somebody who could need that, right? Or coming to you because it's like, well, this is something that you or y'all are really, really susceptible to. So it's like, where's the balance between like, you do need to know probably what that information is, but that also doesn't mean that just because I'm less likely that I don't want to, receive that. I still want to hear about that. I still want to be screened for that, right? And like the only example I can think of right now is osteoporosis because of bone density. And I've heard a lot about, calcium needs being lower for African people because our bones are denser, or we're less likely to break bones, until we get to a certain age. But then it's like, so does that mean nobody's going to screen me for osteoporosis? Or does that mean I'm not going to get, whatever everybody else is getting? Because I want that too.
Yeah. Well, yeah. So, because that's what I'm actually thinking. I'm like, how much of this is preventive care? When we talk about diabetes and amputations, because in our family it happens a lot. I think Grandma had 2 or 3 before she died.
Yes.
I've had some other relatives that had like legs lost, and it's almost normal. It's just like this is a part of having diabetes. But how much would actually be preventive if we had better options, better care, things of that magnitude?
Yeah. Well, no, I think it is important to know about those preventative measures. But I think it goes back to something that you just said, and that is that as it has become normalized in our own communities, it becomes normalized to these physicians in a lot of cases. So for an example, in my dissertation was on cultural competence education for physicians. And when there was an opportunity for people to learn more about their diverse communities, they were insulted that you, in fact, were trying to teach them how to be better in caring for their patients because they know how to care for their patients. So it's not just a matter of the fact that there is preventative efforts to do it. Your caretaker has to be in a position to say, yes, I think something like this is very important. So you go for and the preventativeness is important. As Richard has talked about, we've got a very, very close family. We're very Southerners. We come from a kind of a message, if it ain't fried, it ain't cooked kind of thing. But you go to our retreats and things we have today, we have much more healthy foods in regards to the way that it used to be. And we've got healthcare professionals in the area who can kind of walk through and say, these are some of the things that needs to occur to make sure that we're healthier as it regards to that. So the information still needs to be known. I gave a lecture a couple of months ago, and I was talking a little bit about, again, colon cancer for men of color. And, back in the day, if a physician saw blood from the colon for an African-American man, that automatically kind of meant colon cancer. Well, that's not true. That's not true. I mean, you can have a hemorrhoid that is external, that bleeds. And so as I was sitting there having the discussion with the person doing that, a young man came to me afterwards and said, I'm so glad you said that. This is one of the things that I have been dealing with, and I have been so afraid. So he's already made the jump that he's got colon cancer versus having the discussion about here's another abnormality that could be going on. So the health information in our communities and the things that people are doing at barbershops and the things that people are doing to try and put that information out there is very, very important. And again, 90% of African-American men go to the doctor because they're involved with African-American women who make them go.
This is true. This is very true.
You see what I'm saying?
Yeah,
so again, we as much as all of the discovery is going on, it's still important to get back to those cultural implications in the area of healthcare, to try and encourage people to go and to take care of themselves. And we have tried, as I've been with the healthcare system, we've tried everything. I mean, we've tried everything.
The upbringing makes a big difference. My uncles are very much the same way. It's, oh, well, if it's still bothering me by next week, then I'll go. Or if it's still, it's like, well, how long does it need to bother you before you decide to go?
And we're very episodic as people. We believe if my head's not hurting right now, then I probably don't have no problem with high blood pressure. So we're very episodic. We respond a lot of times when we feel the pain.
Sure.
And that's why things like high blood pressure is a silent killer, because it doesn't manifest itself in ways of pain and all those other things too. It's just important to make sure that we're good. And again, I mean, this is the reason to me that I think the Obamacare, the managed care, was so important, because what it did was it literally took a large percentage of us out of the emergency room as using that as our primary care docs. It gave us an opportunity to, on an ongoing basis, be able to afford to go in and look and see those things that really could be prevented.
Right.
And so that's why it becomes so difficult for people in our community when they said, gee, they had cancer, they went to the doctor, and they were diagnosed and they were dead in 2 to 3 months. Well, that's because it's moved so further along. And a lot of these things are so preventative, but we have to find ways to get people in to get these checks. And we have to meet people where their needs are.
That's true.
You got to meet people where their needs are. I mean, if you say to a person, I want you to go and get this checkup, and I need you to do it in 3 weeks, most of the time they're not going to sit and tell you, I don't have transportation or the ability to get there in 3 weeks. So our ability to be able to sit down and talk to patients today, like one of the things that I included now when a physician talks to a patient is, what is your food situation?
Yeah.
What is your food situation? Because if I'm telling you to take your pills with food, and you ain't got no food in the house, then are you thinking it ain't gonna be effective? So I'm not gonna do that. So a lot of the work has to go beyond just all of the newer issues that we're dealing with to get people in, getting people through, trying to do healthcare through computers and et cetera.
Yeah.
And really begin to still have a focus.
And that normalization of going, would make such a big difference as well, because another reason I think people get dissuaded is because they think that I've got a specific issue going on and I just don't want to go, because if I go, I'm going to have to get a regular checkup and get scheduled for a physical, then I have to pull my blood, I'm going to have to spend 3 visits before I can even get to my issue.
Right.
Well, that's because you haven't been to the doctor in 6 years.
Exactly.
So that's why you have to go through all those steps before you can get an actual issue addressed.
But I tell people all the time now, healthcare systems say we need to provide access to people of color. But even if you have access, you still have to be treated appropriately in the environment that you go in.
True.
If I show up and say that I've got an issue, and your second question out of your mouth is, do you have health insurance, or don't you, or anticipate you don't have health insurance?
True.
Automatically, it makes me perceive that I'm not going to get the level of care that I need to get.
True.
And so it's important that we begin to look at the entire system. And again, I don't want to make it seem as though there has not been some issues that has been done to move this thing forward, because there's a lot in regards to that. But I think it's interesting. It goes back to one of the things that you said earlier, and that is that even in the 21st century, where you've got computers trying to take care of health, they can have a racial underpinning. Because what happens a lot of times, right, is that's exactly right, and it's programmed based upon activity, involvement, treatment, and et cetera. And all of a sudden, if you've got a population of people who are not showing up, it makes it look like they don't have the problem, which makes it look like they don't have the care. And once again, you're back at this lack of care. So there is still a lot of areas that needs to be addressed in the areas of healthcare to try and give. I mean, they've kind of added this thing, diversity, inclusion, and now equity, which I think is fine. And so people say to me, how do you define diversity and inclusion? Well, to me, diversity is being asked to come to the party. Inclusion is being asked to dance at the party. And equity is you can dance who you want with whoever you want to at the party. So when you begin to think about, do we have an environment, regardless of what these environments are, whether they're healthcare or businesses or et cetera, do you have an inclusive environment? I mean, really, do you have that? And as you can imagine, with over 25 years of doing this, I talk to people all the time who they have passion and they have awareness. But passion and awareness does not equal implementation. It only equals impassioned awareness. And so in the last few years, we've really had to get people beyond just this, I want to do the right thing, and what is equitable. You know, how do we make sure that I'm included in those decisions, you know, just like everyone else is?
Yeah.
Instead of just your heart being in the right place. So, and again, there is some positive things that are going on. I don't want to make
for sure.
Like,
we want the meat, so it's okay. It's okay if the meat's all red meat. That's okay.
But historically, there continues to be a lot of racism in the area of healthcare. And until we sit and have that discussion about the racial implications, you know, when I've done discussions before, sometimes I think I get myself in trouble because we need to quit coming up with these new words to define racism. We need to quit, you know, it was diversity, it was inclusion, it's implicit bias. We need to stop doing that. Harvard did a study back in 1937 called the IAD, the implicit test. And it actually focused on whether or not you had biases or not. Over 400,000 people have taken that test. Are you telling me in that period of time, you have not been able to determine that you have a bias? And then if you don't even look at the test and begin to look at the results, so you're telling me that the statistics don't help to do that. And so I feel like we're always putting something in front of trying to address the real issue of racism. I mean, I just...
That test is available online for free, too, if anybody wants to take it.
Yeah.
It doesn't take long.
You would know that.
And I just think it's so interesting now this thing has shifted to this whole critical race discussion, critical race theory. I mean, I think it's amazing because critical race is not a program, it's not a training, it's a construct. It's like Marxism versus communism. It's a construct.
Yeah.
But anything that begins to say that
somebody
racism
might be wrong.
Yes, and racism is not just your feelings. It is embedded, and an entire nation can be racist, and nobody wants to have that discussion.
Yeah. And it's also fair enough to say that you don't have to be you can be a person of color, and my feeling, there are plenty of people who have internalized racism and who project racism in the way that they behave.
Exactly.
And it has nothing to do with whether or not they're a person of color or not a person without color, as they say, PWC. But I wanted to ask too, just really quickly to underline it, when we're talking about amputations or when we're talking about just the outcomes for healthcare, are they always, is it the cheaper option? Is it that that prevention is not explored? Is it that time is not spent? Like, what are all the things?
You know, it's a mixture of a lot of those. So let's say, for an example, cost as an example. There are some issues, especially associated with high blood pressure, as you begin to come to the area of amputations or et cetera, that there are other processes or procedures that could be in place. And sometimes they are a bit more expensive to really try and get those things done. And not only that, a lot of them has to be recommended by your primary care physician. And so it's not a matter of you going in and saying, I read about this, and I think that there's been some great results, and I like to do this. Sometimes you have to be recommended to do these through your primary care doc. So there are those things that, you know.
Is that structural?
In a lot of cases, it is. In a lot of cases. I mean, just trying to go in and address, sometimes you have to kind of go through, again, your primary care doc. And for many, many years, as we have not had primary care physicians and have used the emergency room as our primary care place. When you get sick, you go to the emergency room instead of your primary care doc. So a lot of those areas that would normally be addressed by your primary care doc is not done because they're either cost implications, overlooked. You're not in the study. You haven't been there long enough to do those things, and et cetera. So clearly there is a lot, there that goes into when the people begin to talk about diversity and inclusion in healthcare, and they begin to talk about the impact it has in other industries. It's very, very different, and it has been very, very different in healthcare. Many, many years ago, I worked in retail. I worked for TJ Maxx. And when we moved into an area, we did the demographics in that area to see who was the population and et cetera that we were looking to try and address. And if we had a large Hispanic population, then a lot of my products were products that the Latino community could embrace. Healthcare is very different. Healthcare, you may have a large, diverse population, but they don't want those individuals coming to the hospital. They don't want those individuals going to the doctors because they feel as though it drives the cost and everything else down, and they don't get the reimbursement that they did. So people felt, wow, you've got this population of African Americans in this community, you can take care of them. That's not the way the administration looked at it. They looked at it as a drag on the system, not necessarily an opportunity to really try and go out there and do that. But again, I
that
want
sounds
to be
like
fair.
banking as well.
Well, no, because it's funny. I wanted to get to that because
Right.
remember we had Jay Bush here, and he was saying that if you go above 285, you see this, and if you go beneath 285, you see this. So I was hoping we would get to that point because that was going to be one of my questions. How do they decide where to put healthcare facilities? Because, but like you said, it's clearly not going where, in essence, it needs to be.
Yeah, and a lot of the times that where the hospitals are and et cetera. And again, like I said, in the area of New Jersey, we just had a very big, healthcare system. But it was interesting because, the healthcare systems has a margin just like everybody else does, and they've got to stay afloat. Well, what really became interesting in the area of COVID, we really became the place where everybody was coming because of all the problems that we had. Well, when the COVID kind of went through and started to get better, all of a sudden now we became known as the COVID hospital. And so people who were normally getting their treatments were not getting their treatments. And when you begin to think about the area that makes profit for hospitals, they're like non-elective surgery issues. They're like removing a mole, having some, et cetera. So when you all of a sudden had people not coming back to get their basic treatment, as well as not doing these non-elective surgeries, then your hospital really, really ran into a big problem. So then it became very important that they began to reach out to those communities that they had never reached out before to try and drive some of the revenue and some of those other things that needed to be. So yeah, a lot of times hospital systems will be put in areas based upon the community, and they think they've got to, I'm not going to get very much reimbursement here. Versus on the other end, they put hospitals where it's in a specific community because people they know will be able to afford that.
From where you're sitting, do you have a stance on whether or not healthcare is or should be a right?
I really believe healthcare should be a right, and not necessarily, as people say, a privilege. It just to sit back and to look at how people can be helped if they were better educated, a more welcoming environment, a relationship with a physician or a community that puts health, where it needs to be. And people have a right to do that. But I tell you, I have been so dismayed as other people about what pharmaceutical companies and others have come in for the purposes of trying to, people have to decide, do I get my high blood pressure medicine today or do I pay my rent? That shouldn't be a discussion in today's environment that individuals are having. People are leaving the country to go to have procedures.
To get stuff done.
Yeah,
dental work
to get things done. So, again, the Obamacare was just wonderful for so many reasons. And aside from the health of people of color getting better during that period of time, hospitals had their best profitable bottom line ever. Because instead of you going to an emergency room where your care is 150% above what your normal cost is, now you're going to a primary care doc.
Yeah.
And it was just, one of the greatest thing I think has been done. But again, people have tried to minimize that and et cetera. But I do want to say, because I know the Institute for Diversity in Health Management, which is a part of the American Hospital Association, they have put together a strategic plan to really try and address some of the healthcare issues that are out there. And I was on their board for like 7 years. And so even though a lot of these things we talked about serve as deterrents, they really did do quite a bit, or are doing quite a bit, to try and address, some of those issues. And so, and one of them is like data collection and how you stratify the information. So now all of a sudden I do know who's coming into my hospital who's disabled, who's a member of the LGBTQI community. I do know those individuals that may have health insurance issues and those kind of things. So the collection of the data and the stratification of the data has been critical. But teaching people how to ask for that.
Yeah, I was going to say, what about the advocacy? I don't know if this is a good ending question, so I don't want to...
Actually, y'all killing me because
I think it's a good end question.
Keep rolling because I can't cut it now. We got to
I
keep
don't
rolling.
I don't want to jump before, because I think it's a good ending question.
Well, no, actually, we have an extra hour, technically. I was going to use it for something else, but this is like a special.
I just more want to know, like, how people can advocate for themselves and how you do that if you don't know what to advocate for. Because I think people do want to... do some research. I'm sure they've had conversations. And so I'm kind of wondering, like, how can people better advocate for what they need, or at least ask better questions and, get around the idea that, like, do you need to bring a white person to the hospital with you every time you go? Like, do you need to just ask one of your coworkers, ask Sarah, whoever at the office, like, oh, you got this done, or you went to this hospital, like, can you come with me to the hospital? Because how else do you advocate for yourself?
It's a great question. And I think that when people find out that the process they're using is not working, it's critical for them to think about, how do I do that? One of the things that we've always done, every place I've ever been, is to try to create a close tie with the community. That community involvement is just important. If you go to a hospital and want to talk to the president and CEO, and they don't have time for you, but if you show up and you're Reverend Johnson with 300 congregants with you, they're going to hear what you have to say. So people sometimes underestimate the importance of the community. And so I would say, first of all, the opportunity to create a community advisory group where that community literally reaches out to those physicians in those areas and ask, request, demand that they come and sit and talk to them about ways of trying to get help, trying to advocate, how can they support, how can they help, and et cetera, becomes critical. Because people of color are consumers, okay? And I think sometimes we forget that. We forget the fact that even though they may have to go out and buy a lot more spirometers or blood pressure machines, what's that for? It's because of us. And so you do have an impact on the bottom line of that healthcare environment. And so, again, one, I think it's important to try to approach it from a community perspective. The other thing, too, I think if you do have a relationship with someone who is a primary care person or a physician or in that field, get with them to ask the question, or go sit down and ask the question. There is a lot of opportunities now to write in. There are African-American physician groups now that you can get with and try to find out what are some of the latest things that is going on, and et cetera. And one of the things that is really, really important, and I say this to people all the time, listen to the clinical trials and et cetera that are going on that you might want to hear about, you might want to know about, and at least find out about what they are, and it's something that you may have an interest in, or whatever the case may be. And then also be informed. I mean, there's nothing like being informed and seeing those issues out there, that you can get in contact with a group that's kind of working for that. There's a lot of ways to really try and be seen and heard, especially from your community, about those kinds of things. But it would be, one of those things is I think it's the hospital systems need to know who they're serving. And so that's why the collection of data and how you're stratifying that data is so important. It's called real data, race, ethnicity, and language, REAL data, and finding out how you address that. And that was the importance of diversity and inclusion. Language barriers. The impact that it has on individuals when they are coming to be treated and et cetera. When you say to a person, you need to take, these pills 5 times a day. Well, you've got to clarify, you don't mean take them all 5 at the same time.
Thanks.
We had a situation to occur in the state of New Jersey where a person came in and because of the way that he was acting and they didn't have an interpreter, they used the word intoxicado, which for us means that the person was intoxicated. The person ended up dying with a blood bleed because nobody was there to actually take care of them. And it was one of the largest cases that came up in regards to issues of interpretation. So, there are a lot of cultural implications that still need to be, addressed, in areas of healthcare. And, and I think sometimes they're working to try and get, some of those things done. So data collection was when I just wanted cultural competency training, I think is so very important to talk to people about the cultures, and how you embrace the cultures of people who come into your organization. We've all come up with the issue of, I don't want this person waiting on me because they're a person of color. And what do you do around that? And healthcare system should be saying, this person is as qualified as anyone else. This is the person who we have to try and serve you. So this issue.
Do you recommend people also? I didn't mean to cut you off there. I was going to say, but since you mentioned that, I was going to ask: Do you recommend people go to a different, demand a different physician at that hospital, go to a different hospital altogether, like shop around, look around as much as they can? Like, would that be a way to just insist on seeing more than one person if they need to?
Yeah, I think, and I would strongly suggest that people shop around and look around. Okay, because the healthcare industry has changed, and what I mean by this is, in me and Richard's family and our parents, if the doctor said take this medication, and Richard and I said to our mother, but this medication is making you dizzy, she would say, well, that's what my doctor said. Okay?
That was early.
Oh, yeah.
Right.
That was early.
Now here's the second iteration. I play golf with my doctor. And so if he tells me something, I kind of hang with that because he tells me that. You guys' generation is different. You're not as so concerned about he's the greatest cancer doctor versus does he have the greatest cancer technology. And that's the difference. And so I love the fact that a lot of times younger people will advocate and look around, and in a lot of cases be more proficient than the physician is when they begin to talk about those things. And so I don't believe in going on the web to try and diagnose your, but I think there's nothing wrong with being informed and finding out technologically how sound people are versus historically your mother said 37 years ago they did this. I mean, I think it's important to really try to look at that. And I tell you that I've seen young people in a line in a hospital waiting while on their phone looking for another physician. I mean, it's just not the, and so again, I would say this to my healthcare system all the time. People are not so enamored by the fact that this is the greatest person in cancer. They just want to know what is the technology that also supports that kind of behavior. So yes, I definitely subscribe looking around, getting second opinions, not like it used to be around that.
Okay, so because I have 50,000 questions, but I think my biggest question is healthcare bodies, because to the average Joe, you have hospitals, but then you have urgent cares.
Yes.
And then you have, I I think it's Concentra or something. They send you to get like drug testing things at magnitude.
Clinics.
Are these all the same bodies? Are they governed by the same head, or are they all different entities that have different objectives and goals?
Well, it's interesting because if you look, let's say if you went back 20 years, you would see, and I'm going to use this as another industry, you would see that all of retail was kind of coming together. You know, in other words, you had one business buying another business, buying another business. That was 20 years ago. 10 years ago, healthcare started to do the very same thing. So in other words, if I was a good primary care hospital, but I didn't have cancer treatment, then I went out and found somebody who had cancer treatment and I brought it under that. So that is why today you have such large hospital systems. It's difficult for a hospital system to be freestanding and not have all of those other areas. So think about it very much in a sense like a Walmart. You ain't got to go out of the building to get what you need. So what I need for you to do is have registration right here. I need you to have testing right here. I need you to have x-rays right here. I need you to have whatever else. And I don't need you to leave the building for any of the things that you need to have. Now, the other thing is I want to make sure that your primary care physician is a part of my hospital. So in other words, then I want to develop a relationship so you do your surgeries here. That's where the money is made, you know, with the surgeries, et cetera. So in most cases, when you have a hospital system, it has all of those other ancillary areas under it. And so a lot of times it may say Hampton General Doctor's Practice or Hampton General Medication or whatever the case may be. But that has been the push over the last 10 years to bring all those ancillary businesses underneath one roof. And so you don't have to do anything. And that's why the computers are so important, because now your records becomes transparent. Right. You may go from here to someplace else, but I already got your records. I already know your information, and I can take care of you.
I mean, they still ask you what your allergies are every time.
Yes, exactly.
But anyway.
But the intent is to be transparent.
I hear you.
So that, you know, that can happen. And so the system literally tries to pull all of this together.
Okay, we still missed you. So, because I'm giving us a little more time. When you stepped into healthcare, what were the major issues? Like, what were the major things you want to tackle when you stepped into diversity and inclusion?
Yeah, well, let me tell you how I got into healthcare.
I was going to say the why.
Right, because I had always been in retail, you know, open up these businesses and et cetera. And most people don't know that, you know, early on I was a single parent. You know, I had custody of my daughter, you know, from the time she was 3 years old. And so my daughter was very much like any other child. She was a cheerleader. And so as the football kids had to go in and get checked, my daughter had to go in and also get her checked. And so here I am taking my 7-year-old in to get her annual checkups. And I would hear the nurses mouthing, I wonder where the mom is. Why doesn't dad step outside while we talk to the daughter on the inside? I was so impacted by trying to do the right thing and behave like I was doing the wrong thing. And I said at that point, I never want anybody to feel that way, which was kind of my impetus into healthcare. And I really didn't know how to get in healthcare because I was working in retail. But then there were board opportunities, governance that came up. And because, you know, I was an executive in the area, I got a chance to get on the boards and begin to look at some of the governance structures and could clearly see how a lot of this was not for the part of embracing the community. So to your point, Rich, when I talk to young diversity leaders, especially in healthcare, one of the things I say to them is, don't forget that you're still the voice for people who don't have a voice. I mean, you can share how much you know about healthcare and how much you know about technology and how much you know about this, that, and the other. But those individuals are not asked to do your job as you're asked to understand their job. So don't forget you're that voice, number one. That was the one thing I wanted. And don't be afraid. I mean, there have been so many presentations I've gone into that I'm like uncomfortable to make the presentation, but I'm not afraid because the information is basically what the information is, you know. And if you are smart about it, you'll understand that we're on the same page. So when I have talked to organizations and they have said, what do you do? What do you think are the most important things to happen? The first thing you need to do is develop a strategic plan. Because when you begin to talk about diversity and inclusion in healthcare, everybody has an opinion and an idea. And they all want their opinions and ideas in place. So if you develop a strategic plan, develop it 3 years. Because you say to them, I might not get to you this year, but your issue is coming up. The second thing is develop a group of leaders who can make decisions so that this issue is not on you by yourself. Diversity executives are the only one who are asked to come in and change a culture. And a lot of times without given the resources to really be able to do that. And as I said, according to who you're talking to, people are coming from all kind of places. We think women, we think LGBT, we think the diverse community, we think people are not getting treatment. Some people are trying to atone for racism. I mean, so to me, the issue was, how do I come in and make sure that people understand that I'm not afraid, that I'm going to address the issue, I'm going to call it for what it is, number one. Number two, how do I make sure that people feel comfortable doing the right thing when they come in? How do I let you know that my mom, who is 80 years old, you don't call her Alethea, you call her Ms. Boatwright. And so when you begin to realize that there is a gap between you and the physician, think about how that introduction was made. Well, don't make that mistake, you know? So my feelings have always been, once you begin to address the culture, you're then beginning to address the health of the person, because nobody feels better than being understood.
Oh, for sure.
Then, right,
sure.
you can move on to the next thing. So that was important for me. I really don't know if I did as much in the organization of getting people moved to some of those areas that they needed to, as far as promotions and et cetera. But I really did do a ton of work in the community, which has allowed me to get to those individuals and kind of permeate some of those things. So that was important for me. And I wanted people to not be afraid. I mean, we in healthcare, we have this healthcare speak, where, tell me what you're asking me to do. And sometimes the language is at, 11th and 12th grade, when most of the people are at third grade level when it comes to that kind of thing. So stop with the healthcare speak and tell me specifically what it is that you want me to do. Be able to realize that sometimes people don't, I'm going to give you your medication. Well, I didn't bring my glasses, or I'm going to get my kids to read it. Well, you can't read. Understand that these are the issues that people are dealing with. So, again, I think that sometimes we kind of jump over.
For sure. The person.
The person and the basic things that is needed for people to care. And that was one of my motivations, Ricky. I wanted to make sure that if there was any, the most colorful conversations I have is when Ricky's dad, my cousin, when 15 guys are together, and we still do the same thing like a lot of African Americans do. Men out there under the porch, drinking and cooking, the women are in the inside. That's where we're having all the discussions about our health. Well, what's your number? Well, my number's been 4. Well, where did you go? Well, I had retention. And so again, we need to have professionals in those areas so that they can, begin to help in those communities.
So now I can tell my mom what they be talking about under the
shed.
Yeah. We always try to figure out what they be talking about under the shed. They go straight outside. It's a thing. Let's talk about strides that we've made since you got in there. Because, we like to leave with some good stuff.
Yes.
So let's talk about some strides.
Well,
that
again,
have been made.
I'll go back to some of the domains that the IFD did. And again, as I talked about the data collection, we are much better now on collecting the data and knowing the patients that we have. And the percent of patient records with sexual orientation, gender identity, disability status, and all of that, but also creating a staff who now knows how to appropriately ask that question, which has been important. The cultural competence training, I think, continues to be important, because a lot of times what people don't understand is that you still create distance when you create what they call these microaggressions. And the microaggressions is simply not introducing you, not calling your name correctly, not inviting you to the meetings. And though people don't think that these things impact them, it reinforces that separation when you do these things. And so cultural competence education needs to include that. And there's a lot more of that. The implicit bias training, I think, continues to be important with people to have, learn about unconscious bias. So the training is something. The diversity in leadership and in administration. And so that ability to try and attract more than 4% of physicians and women in those ranks are very important. And so now schools have literally begun to put in place these numbers that they're trying to get to make sure that you have individuals of color in that. And we have gone back as far as starting our training in the 6th and 7th grade, reaching out to people, having a relationship with them. And then when they get to be seniors, literally helping to try and drive them to medical schools or whatever else it may be. And then governance is important. I mean, there's this big issue about the fact that it's hard to find people of color to sit on the board. And that's ridiculous, because there used to be a time that they felt when you were going to be in governance, you really needed to be able to contribute and have enough dollars and et cetera. But here's the thing that people forget. People of color contribute to nonprofits because we support our churches. We support them in a very big way. So why is it that I'm comfortable supporting that structure and not this? Well, I may not be able to sponsor the park, but I may be able to sponsor a bench in the park in my mom's name. And so again, you've got to look at different ways to try and get people of color in governance and et cetera. And I'm sure the person that white America may think is the leader in our community is not the leader in our community.
Yeah, especially now.
Right. It's Reverend Jackson, and it's the person who run the food. It's that's and that's one of the things that also became important. So it was important for us to make sure that we had not only in leadership but in governance around that. And that was one of the other things that we're doing. And then I think just finally just kind of strengthening the community partnership. I mean, that is so much so critical. When we were trying to do lead abatement and lead paint into these homes, and when I was living in Michigan that were built, back in the 30s and et cetera, and these kids were being impacted by lead poisoning. They wouldn't let anybody in your house. You see what I'm saying? So in other words, I'm knocking on the door. I'm in my shirt and tie. I'm coming to see whether you have lead-based paint. I don't know you. I don't know nothing about you. So all of a sudden, we literally started to develop and educate community workers, people who had a relationship in the churches and in some of the other areas. Reverend Johnson, how can I help you? I'm trying to find out, honey, if you got lead in your house. Well, come on in. Because a lot of times in the house may be people who shouldn't be in there based upon whatever, and et cetera. So developing those and working very close with the community was another domain. So those kind of domains were those things that we really try and do. And I try to do a big job in recognition. Black History Month, Women's History Month. Those were very, very critical. And we created a lot of specific groups at the organization for the purposes of trying to help the hospital system. So if we had an affinity group, and an affinity group of, let's say, our LGBTQI community, it wasn't just so people would be aware that they were there, but what are we doing and how do we do to make sure that we're marketing and creating an environment so people who are comfortable
to shift
come
the culture.
Exactly, and come to our hospital. There are so many people out there with issues that won't come to the hospital because of the stereotypes that they're impacted with when they get there. Who wants to be treated like that? On top of that, I don't know what the hell is happening to me, and now you're treating me like this. And so there needed to be a greater education when it comes to that, and a greater level of respect and how people want to be treated and how they want to be recognized and those kinds of things too. And so we have been going a lot more internally and trying to be better, in trying to address those issues.
Okay. Any more questions from you?
No, I just wanted to thank you for sharing the knowledge that you shared and for giving people some actionable stuff. Like I really like to share with people not just the information, but also maybe what you can do. So I like that you underlined that we should not be diagnosing ourselves online, but that there's also nothing wrong with going online and seeing what experiences people have had in certain places.
Exactly.
I leave very detailed Google reviews myself. So when I have received any level of medical care or medical attention, I'm very quick to go to Google. I actually have a lot of stars in my profile. You can follow me at the Simone Shuri on Google. So you can, if you are in the Metro Atlanta area, chances are I have seen that gyno or I've seen that physician. I'd be happy to tell you what I think. So
Sometimes
Thank
I
you.
worry.
And I think that is so
worry.
important, Simone. I mean, I think that people just willing, for some reason, and again, when we would do a lot of the presentations, people thought that I, as a presenter or the physician who was a friend, weren't going through some of those issues also. We are dealing with the same. It doesn't make, I'm not better, I'm not healthier because I was in healthcare. I'd like to be, but I neglected some of the things just like anybody else did too. And so for you to say, listen, I probably dealt with that, or if I haven't dealt with that, I can connect you with someone who has.
yeah, I'm sure that
really
makes a
becomes
difference.
critical. Really becomes critical.
All right. Any final thoughts, Doctor?
No, I just so much appreciate you guys having me. And again, I haven't always been the guy who plays well in the sandbox because I address the issues of racism, which speaks to a lot of where this really comes from. And I think we have to continue to work on trying to create a healthier environment. You know, the numbers are getting better in a lot of areas. I appreciate what some of the hospitals and the physicians are doing. I encourage our young people to still go in and have clinical studies and do some of those areas. But the diversity, inclusion, and equity in healthcare is so critical. And I'm not saying the other industries are not, but because of how racist it
Your
has
life,
been
yeah.
and how it continues to kind of raise its head. So thank you so much for having me.
Thank you.
All right. So once again, my family dazzles because it's what we do best. So special thanks to Big Cuz Dr. Wayne Boatwright for being with us today. And I'm just floored. Like, you know, we normally go an hour, but I can't stop this because this is probably going to be a special, a Black History special on the television channel because it's just a lot of good information. It's conversations we don't have, you know, which Dr. Bush is coming back. We have good conversations, but to really get into diversity and inclusion in healthcare, which is so impactful on minorities, is conversations we got to have. So when we find professionals, family or not, definitely want to get them in so we can have these very hard conversations because they need to be had.
You know, and Richard, and we shouldn't feel ashamed or uncomfortable that a lot of times we don't know. And I think a lot of times that's part of the things that stands in the way. We need to break down some of the stereotypes and some of the issues associated that keeps us from doing the things that we can. I mean, mental health for people of color has never been one of those things that we've talked about. We just kind of put people aside until they, and we've got to stop doing that. And I think in a lot of areas people ought to stop doing that. But people shouldn't feel bad when you gotten cancer. You didn't do anything wrong. You didn't do anything wrong. You know, but let's address it so that you can at least have a longer and beneficial life.
All right, you guys. We will see you guys same time, same place on the Leadership in Live podcast with your host, Ricardo D. Rice.
Thank you. This is great.
I know